Thank you, and thank you, Sean, Ken, for having us here. Sean asked us in this time to just talk a little bit about what we're doing in our areas with regard to talking about PrEP and having that community conversation. So I'll run through that pretty quickly, but want to also comment on a couple of the other things that had to do with testing, and I'll throw that in a little bit later too. So how many of you ever heard of PrEPFaqs.org? Yay. San Francisco people.
Of course.
Well, everyone should go to PrEPFaqs.org. It's a website that we created, very consumer friendly. It's a great online resource for primarily gay and bi men to learn more about PrEP, dispel some of the myths and misinformation out there in the community. There is a pretty lively conversation taking place in San Francisco, especially in the gay and bi male community, about PrEP. The website came online right around the same time as we were helping with recruitment efforts for the demonstration project at San Francisco City Clinic, a very targeted media campaign. Someone mentioned that a little bit earlier today. Bus shelters all throughout the city, especially in the gay area, online, print ads. So it's had a pretty strong presence. It's about a year old. We've had 12,000 people visit the website, over 21,000 page views. The most viewed page is the FAQ. Just what are the questions and answers. So that's been helping us inform it. We're going to be relaunching and reevaluating the site and putting a whole bunch of new information on it before the end of this year, actually, to get it going for 2014. Interestingly, because of just the way that it has all been created and the way it has gone about, one of the things that we're doing in the next phase is actually involving people in the community to help talk about the content and talk about the information and pulling in some focus groups and having people help us. What was on there that was helpful, what wasn't helpful, what do you want more information about, where are we kind of dancing around the edges a little bit, and should we be a little more direct? And we're finding that's going to be really, really helpful for us as well. The messaging is really important and kind of comes into one of the things that was talked about earlier. One of the reactions that we're finding in San Francisco, and I think this was about changing the paradigm, I think we're actually still creating the paradigm. And I think with regard to PrEP and the messaging, we have some work to do. Because one of the things that we're finding in San Francisco already, especially with the online community, is Truvada whores. That's the term that's going around for the HIV negative men who are self-disclosing that they're on PrEP. Well, they're Truvada whores. We have to address that. And we have to talk about the implications of that conversation going throughout the community, and what does that mean when we're trying to reach people to possibly go on it. And I think the whole concept, we've been talking about Truvada as PrEP for at-risk populations. So someone, and that's sort of the pervasive message, right? It's for at-risk populations. Well, then you hear some folks in the community who may not either self-define themselves as within an at-risk population, or more broadly defined may not be an at-risk population, but they're going on PrEP. And their friends and everyone else is now making assumptions about their behavior. Maybe, Phil, maybe we're not talking about our sex with all our friends as much as you are. But it's an interesting kind of a thing, because now we had a conversation with a 26-year-old young gay man in San Francisco just a couple of weeks ago who has gone on PrEP. He has very clearly said, I don't really fall into any of what you're saying are the behaviors or the at-risk groups, but I feel like I should go on that because I'm a gay man and I'm having sex, and the time may come, or I may meet a partner that I don't want to have protected sex with, and so I feel I should be on that, but so I think this whole conversation, we still need to think about that, especially when it comes to the messaging. So that's something we're going to be spending time on, because we're getting some initial feedback that's really interesting. We also have, how many of you have heard of betablog.org? There's a few hands, good. So betablog.org is our sort of the online version of the very traditional beta that's been around since 1988. Building health literacy, all of those sorts of things. So we have more than 30 articles now, Q&A and other topics and so forth related to PrEP that are on there. We have, there's an iPrex update with Dr. Robert Grant. We have a monthly column called Promiscuous Gay Nerd. Maybe we're not helping the messaging there, I don't know. I'll have to go back on that. But kind of columns about the 21st century gay men's sexual health experience, who is the PrEP user, who is not the PrEP user. And again, we have to look at the messages that we're sending out. But we had a recent column called What Makes Sex Good? Exploring a gay man's unspoken needs, sexual needs, desires, the role of PrEP and understanding all of that. It was viewed over 1,000 times within 24 hours of publication. So we know there are people out there that are hungry for the information and want the information, and so we're trying to get more and more of that out there. Real quickly, and then I'll use up my 10 minutes, with regard to testing. We really believe that the testing component is really important. We have now worked into all of our prevention programs, messaging about PrEP, whether it's our Latino program, our Black Brothers Esteem program. All of our outreach prevention programs have a component now with regard to PrEP, to talk about PrEP, which we think is important. We've moved to the fast lane of service. Magnet, which is our sexual health clinic in the Castro, has fast lane service now. And in the first year of the fast lane service, we went from 4,500 tests to over 9,000 tests. So capturing and finding those folks who don't know their status, obviously really important with regard to everything that we're doing. So let me stop there, and then I'll get to some of this other stuff. I'll throw it in during the questions.
Obviously, I campaign for Como very much. Not much, but I think many of you probably knew or heard about Dennis De Leon, a true pioneer, a true leader, and Dennis was really a visionary. And I was lucky enough to land it under his wing, and he embraced me, and we did amazing things, and we still honor him. We lost Dennis in December '09, and the board asked me to obviously to cover the organization. Thank you so much, Sean and Mayor. The Mayor, really honored to be here with all of you. And basically, I'd like to share a little bit. Probably some of you know the Commission is a local, regional, and national organization. We strongly believe that one of the best ways to do better our work is to learn from other communities and organizations, Asians, Native, African Americans, Anglos, etc. But in terms of the challenges that we have and the changes that we have to make, we truly believe that the engagement and thinking and acting outside the box is a must. And we have been talking about the 50 plus or the 50 plus territories strategy is essential from 2010 through now and the years to come. In the context of PrEP, at the local level we have several, one of our priorities actually is to engage the Latino gay community. And probably if you know about Latinos, Hispanics, you know that we have the challenge of dealing with Hispanics US born and Hispanics foreign born. And then our strategy has to be customized and tailored to that reality. And on PrEP, our priority has been focused on education. We truly believe that it's our responsibility, the conversation of treatment as prevention, but also prevention as treatment. And then put us also, I think, in the driver's seat to try to integrate both concepts. But in PrEP in particular, we do conversations, discussions, but we also understand that we need to engage the largest Latino gay community. And that's a difficult task because that's not the traditional community that we try to bring in. Or targeting transgender women, that also is another segment that we try to work and support for many, many years at the Latino Commission, the work that we do. And we also understand that it's a big difference to be a gay man in New York than North Carolina or in any other place in the South. That is a program that we run, Latinos in the Deep South, and our team report to us all the time that is more complicated when you have to really enhance your rural and urban strategy and also be mindful about what I was saying about the Spanish and English messaging and educational initiatives. But I want to share with you also that in terms of bringing or reaching gay men that are negative, HIV negative, we truly believe that we need to go outside our comfort zone and really develop some strategies that will be very innovative and also that will connect with key social networks. And the team that direct this work at the Commission, if you're ever in New York, come and see us. We're very proud. Why? Because they're really to engage both areas. You know, the traditional 20, 30 groups discussions, and then reaching 400, 450 gay men. That is very rare to see that number of people showing up to an AIDS organization. I truly also believe that since 1995, we have been running a program and learning a lot from the Black AIDS Institute in terms of treatment education. That is important to also incorporate as another module the whole conversation of Truvada as a new important tool and the prevention tool to address the impact of HIV and AIDS. And also I will conclude saying that the big challenge in terms of the changing paradigm that we're facing is that it's essential for us to understand that community-based organizations are important partners. The problem is many of us have been putting resistance to change and to engage. Let me give you an example. All those committees that I have been part at the state level, HIV and AIDS is not a point of discussion or concern for all of them. And I think we have the responsibility to show up and ask some tough questions. I was invited to a DC meeting with Secretary Sebelius, and I asked her, can you list for me what you're doing to engage LGBT to promote Affordable Care Act? She looked to her right, to one of their assistants, and he was quiet. The other person was quiet and said, I'm going to get back to you on that. And by the way, nobody else in the room asked that question before. And I will only remind and took away something from Phil Wilson about the messenger matter. You know, if we don't raise some issues, nobody else. And I think my gratitude to this conversation is because things are changing. Next year is going to be 37 new gubernatorial, I think, elections, and the state legislators and governors are going to be shaping the access for health care. And if we are serious about dealing with some stigma and homophobia and eliminating health disparities, we better revisit our strategy. And please don't forget about Puerto Rico, because many times you see slides, you see 50 states there, but you forget about the territories. Just to give you a little fact, you know, I'm sure you know HIV is horrible in Puerto Rico, but 20% of the population in U.S. Virgin Islands are Latinos. Thank you, and hopefully you will ask me a couple of good questions.
Well, Ben, I want to thank you for organizing this panel, Age Before Beauty, which I think was really smart of you. Ben and I continue to work together, so I had some influence over that. Anyway, I'm glad that our panel follows the panel on community health centers and really builds on some of what Phil's comments were. Of course, all Phil's friends, gay men, talk about all the sex they're having, and all of his lesbian friends talk about all the sex we're not having. So we share a lot in common. I just wish it was a little more. But anyway, we can make lesbian jokes more than you guys can. So we're very lucky in HIV that we have a system of community-based care. And to the point about diabetes before, Katie Caldwell, my good friend from Legacy, often says that when a new doctor comes to her clinic who's not an HIV doc and realizes what they can do for their HIV patients that they can't do for their non-HIV patients, it's really remarkable. And we have to do a better job of understanding that what we've built in this country for a system for HIV is the medical home model that is applicable to other chronic and behavioral diseases. So we're actually at the forefront, and I hope what we've built, not always as effectively as we should, are culturally competent local grassroots organizations that should reflect the populations they serve, should have peer-based support available, and should be used as a way to get the word out about PrEP. This is what we do in every other part of the disease. Whenever there's a new treatment, we always talk about it. We at AIDS Action have an HIV library. Eric Bruss, who's here today, he will talk individually to any of our clients who are on drugs, new drug treatments that might be out there, And we organize our system, and I'm just using us as an example, but there are many others. To get people into our system, we target some programs. So we have a male center, MALE, which is in the south end of Boston, that's very focused on getting gay men in from the community to get tested, not only for HIV and STDs, but Hep C. It's designed in a way to be supportive, gay-friendly, staffed with peers, staffed with gay men, so that folks feel comfortable coming in and getting information. PrEP is incorporated right into those discussions. We have a program called Youth on Fire, which is targeted to 18 to 26-year-olds, homeless, housing unstable kids. Again, folks who are at risk, and they come to us, and they come to all AIDS service organizations around the country because we can offer them something, because they're low threshold, because they can come in some instances and get a cup of coffee, or come in from the cold, or get some air conditioning in the summer. Our Jamaica Plain office, which isn't too far from here, is in the middle of a part of a community in which there's lots of folks who are underprivileged, who don't have resources, who don't have regular meals, who have drug addiction. And we are a nice place they can come and feel like they have someone to talk to. That's how you start educating people about PrEP. You have discussions with them about the kinds of what's their partner involved in, how are they involved. They come to you because you can give them something, a meal, protection, get access to legal services, and you build that trust. And it's that relationship that can make a difference in helping to get patients better educated about how to deal with the medical system. Not to take the medical system off the hook. Certainly doctors have to get more comfortable in that. But if you think about healthcare reform, really it's 3 phases, right? It's eligibility reform, which we've had in Massachusetts for a while now, and which we're trying to roll out now in the country. Already in Massachusetts, we're in phase 2, which is cost control, right? And we still have some new legislation around that. But phase 3 is really transformation. And part of what's keeping us from getting PrEP out there is that we still haven't transformed the system from a disease management system to a health and wellness system. But if we start using things like universal payments and we start holding healthcare providers accountable for better healthcare outcomes and results, then to some of the barriers that got raised earlier, well, why would I put somebody on PrEP if they're not sick? Well, because if they get HIV, you will own the medical expenses for them. And so the more we can begin to align our reward system, right? We won't get behavioral change if we're still rewarding people for disease management, but asking them to do something else. So when we can all talk about people don't have enough time, people aren't comfortable with these things. Believe me, they'll find time, and believe me, they'll get comfortable with it if it means they get paid. That's the way they get paid. So that's why just a few months ago, we announced a new strategic partnership with the Fenway Community Health Center, because we in Massachusetts as an ASO believe we need to be more closely tied to medical providers, because we can create a benefit for them as they have to transform their system to be more connected to people, to be able to reach out in the community and serve people where they're at. So I actually think that AIDS service organizations across the country can play a very significant role in educating people about PrEP, encouraging them to talk to their physicians about PrEP, and really begin to get the word out. And I totally agree, Neil, it's the language we use in each of the populations is going to be critical, but as we know, different cultures and different communities will require different key messages, and I think the people who understand those communities are the people at the local AIDS service organizations. So thank you very much, and now we'll have time to discussion and questions.
Questions for our panelists?
So this is more, I guess I don't need a microphone, not enough. This is more just something to chew on and about messaging and how we talk about these things. Throughout the last day and a half, we've often referred to as taking Truvada as unprotected sex or high-risk sex. I think that's a problem. That's confusing to us, obviously, and it's confusing to the community. If you're taking Truvada, where you were not using condoms, you have protected sex. Is it perfect protection? No, condoms aren't perfect either. So I think we need to stop valuing the condom as the only way we talk about protected sex. And if we're trying to reach people who have already chosen to not use condoms, this is the other side of that coin. This idea that, oh, we have to promote Truvada in conjunction with condoms, we're losing people. If you're telling someone who's not using condoms, hi, I have this great new thing to protect you from HIV, you gotta use it with a condom. And you haven't used a condom for the last 10 years. Or you have decided, you voted against condoms before you ever knew what PREP stood for. We as a room and leaders in this room, we have to get our messaging straight. And this means we're gonna have to take some hits from people who are gonna call us Truvada whores, Truvada pimps. We don't care about our people anymore. We're just shoving them onto pharmaceuticals for their entire lives. But we have to keep it real, because when we're not keeping it real, we have these fuzzy ways of talking about it, and talk about someone, who's taking Truvada as now having, high-risk sex. No, they're not. And if we keep saying this, it's no wonder that our communities are confused and why would someone go for Truvada hearing all that stuff? It just confuses the issue. So I think in whatever language we use, in whatever ways, in whatever cultures we're dealing in, we have to have pretty strong statements about, where Truvada can fit into someone's lives. And we're not gonna, I hope we're not telling people, good little condom troopers, because they do exist, people who take and who wear condoms every single time they have sex, maybe even if they're not having sex, they wear condoms. We don't need to tell them to start taking Truvada. They don't need Truvada. So there's plenty of people who don't need it. The people who do need it are people who are already not using condoms.
Great panel. I want to take us back actually to a point that Phil made around people in the early days going in and saying what they needed and demanding treatment. And I'd love to hear from each of you. Because in many places, we need to get ACA up and running, we need Medicaid expansion, etc. But also demand creation is a big part of this nut to crack. And I think that's part of our mission here too, is demand creation. It's a huge one. Not just around PrEP, but I'm really asking now, I'd love to hear your comments around demand creation for antiretroviral treatment for people who are living with HIV.
I think it's a great question, and I think part of what we're doing by integrating messaging about PrEP throughout our entire programmatic platform is the beginning of that. I think the next step is moving toward very specific referrals and information, perhaps the way we do with some other issues. People want to be referred for this service or that service, and being really clear about it. We also have to, I think we want to do that in coordination with other providers and other service delivery platforms within the city, so whether it's Stephanie's area or others, so that we're all sort of saying the same thing and we're not overwhelming any one particular area, but we do need to move toward that. I know we're doing that. I don't think I mentioned, but just at in the clinic with Magnet, we're getting a lot of interest. We're getting a good 5 to 8 people a week asking about PrEP and wanting more information about it. So we're doing a lot of that very verbally right now, but it does need to move to that next level and be a more formal referral and information sharing.
Thank you. And just to clarify, I'm really asking also about demand creation for AIDS treatment.
Yeah, and the only thing I would say, Chris, is I do think it's more complicated in some ways now. The average income of the people we serve at AIDS Action is less than $10,000 a year. They're not used to demanding anything. So in the early years of the epidemic, let's be honest, the people who were demanding were the well-to-do, better educated white gay men, not the Haitians, right? Because the Haitians were still underground, not even wanting anybody to know they were in the country, much less demanding service. So we serve, many of us serve people who are not in any position, transgender women who don't feel entitled to demand. They just want, they want to sort of come in and try to see if they at least find an environment. So part of it is just broader sense. This gets back to why HIV still exists. It's social justice issues. Women don't demand, historically, particularly in certain cultures. So part of this is we are having to overcome in some areas. Now, I think it could be true in some pockets of the gay community, and I think that's the great thing that some of those men did in the early years. Their demands opened up streams of treatment for everyone, so I'm not saying we don't demand, but I think part of what we try to do is build the confidence in the people we're serving that they have a right to demand, and they have the language they need to do it in a way they feel confident about.
I like to add, and thank you for that question, Chris. I truly believe that, that's the challenge, I think, for all of us. We want to review and update our overall strategy, but also we mindful about that in our case, for example, treatment education that we dropped it long time ago is a very key component. And we know that every time we do a treatment education in Spanish or in English, the whole 2 days or could be 4 days training, and mostly case managers, health educators, etc., they really come back and give us a great feedback. Why? Because they are able to provide also tools and materials to those living with HIV to stay in care. Because when we look at cascade, even though you can revisit, state by city or state, but nationwide, we're not doing very well. And I truly believe that it's our responsibility, and I definitely agree with Rebecca, that we need to engage with medical providers, but at the same time, we need to be very mindful about that we might need to somehow revisit or revamp. We did a training in Puerto Rico a couple of months ago. It was for 60 people. Over 100 people registered for the training. And it's a need, We just did one in New York, 2 weeks in North Carolina, and I think in early December in Florida. It's on demand. I know that Black AIDS Institute also does treatment education. But again, in San Francisco AIDS Foundation, and I'm sure, Rebecca's shop too as well, is how we revisit, revamp, and reorganize and keep ourselves grounded for the needs of our communities. And also, I will also remind all of us, and I hope that many community-based organizations develop a robust leadership development. Why? Because we need to be mindful about association plans in order to have people on the ground. We do that big organizing event in October or November with gay men, like over 450 show up. We pick 70 of them, and then we do a retreat in December that we call the leadership weekend. It's a lot of fun, that weekend. But those 70 individuals, we know that we are motivating individuals that will generate a domino effect to spread the word. Because as Phil was saying, most of the time will be one-on-one conversations that will have more impactful than the conversation if you have it with your physician.
And our last comment question.
So I totally agree that it's difficult to demand when most of the populations that are most impacted by HIVs are the disenfranchised populations. And but I also want to share that, like globally speaking, like we're moving back to a right-based approach and really looking at this as a human rights issues, and also looking at how we can educate our communities on their rights to have access to affordable and available treatment, whether it is PEP or PrEP. One other thing that I want to point out here is that there are some populations that are still very invisible while we're talking about this. It's the Asian Pacific Islanders, the Native Americans, as well as the sex workers. And if we really can't have that kind of level of transparency conversations and honest conversations, whatever strategies we're trying to engage, there will always be a gap and missing pieces.